practice and finding ways to advance high-quality, equitable care. I am super excited to turn it over to Dr. Moore now. Thank you so much.
Okay. Thank you, Adele. So we are going to get started. We called this the third in our series, an STI presentation about special populations. Can you hear me? Yeah, you can hear me. Okay, good. It's going to be a bit of a potpourri of different topics. So I hope you enjoy. I hope you will learn a few things. Here are our learning objectives. We're going to talk about STI trends, specifically among men who have sex with men. We're going to talk about HIV, pre-exposure prophylaxis. We're going to give a little bit of an update about monkeypox, doxycycline as post-exposure prophylaxis, and then we will talk about some approaches to STI evaluation and treatment for transgender people. Okay. We have no disclosures, myself and Dr. Dalby, who is right here with me. She's going to chime in at different points, but let's delve into objective one. So thinking about STI trends. So we've already reviewed in this series some different trends of STIs nationally and here in Wisconsin. How about men who have sex with men? Well, it's not the easiest thing to find data specifically with regards to men who have sex with men. Overall, HIV trends are down from what they were a decade ago, which is great. Shows that the interventions that we've got with regard to HIV PrEP and linkage to care and viral suppression are all working really well. Men who have sex with men account for about 70% of HIV infections and new diagnoses, and that's been stable over time. So if you can imagine, that's been roughly stable over the course of this chart that you see here. How about syphilis? Well, the news is not so great. Syphilis is increasing across all categories of people, especially among men who have sex with men, where it's already higher than the rest of the sexually active population. And what I want to really focus on here is that look at the number of syphilis diagnoses over the last couple of years, which have been occurring in non-STD clinics. So that is to say, people who aren't necessarily seeking care for STDs, but nevertheless, they're getting diagnosed and hopefully treated for STDs. And it's out in the community. It's not necessarily in clinics where they're seeking care for sexually transmitted disease. Here, again, we have a different breakdown of the same data showing syphilis, how it's increasing over time, and more cases occurring among men who have sex with men than among women. But do notice that women are starting to also increase since 2019 and have become the second biggest group of people being impacted by syphilis. Men who have sex with men account for about 35-ish% of the new diagnoses, maybe a bit more, because there's a big segment of people who we don't know who their sex partners are. Women accounting for about 20%. And this is from 2021 data. Wisconsin is up there among the different states that we have good data for. 546 cases in 2021, and that's ranking, up there among with some of the higher, more prevalent states. How about gonorrhea among MSM? It wasn't easy to find longitudinal data for gonorrhea prevalence among men who have sex with men, but the CDC does have this slide, which shows that in 2021, gonorrhea cases were more prevalent among men than among women overall, and for most age categories, more prevalent among men who have sex with men, except the over 40, in which it was slightly more prevalent in men who have sex with women only. All right, so that was a very quick review of some recent trends. Let's talk about HIV PrEP. So USPSTF statement from 2019, and this was reissued this year in August, saying that we need to be offering we need to be offering HIV pre-exposure prophylaxis to people who are at risk, and this is an A-grade rating. When it was reissued this year, they included the injectable option as an acceptable option, and so that means that it should be covered by insurance, and we'll talk about that. Coverage with PrEP is sadly not very equitable among men and among white men especially who are indicated for PrEP. The coverage is good. It's about 60%. Among men, it's decent, 26%. But among people of color and among cisgender women especially, the PrEP coverage is very, very low. And this data is from a 2019 epidemiologic estimate that the CDC put out. And as a result of this, they're really having us push to get more PrEP coverage for women and communities of color. So here's the same data in kind of graphic form. So in 2021, of the 1.2 million people in the US who could benefit from PrEP, only 30% were prescribed it. Among cisgender women, only 10% of people who could benefit from PrEP were prescribed it. And then among Black and African American people, 8% of people were prescribed it. So there remains some disparities in HIV PrEP, despite the fact that we should be offering it to people who are at risk. And I hope that you can help your health systems and your communities bridge this disparity, because it's definitely something that we can do to further decrease the new number of HIV infections. Who is at risk? The USPSTF says that people who are sexually active within the last 6 months and they had a sex partner with HIV, or they had a bacterial STI in the past 6 months, inconsistent condom use, and then if someone kind of seems like they have risk factors, like a high number of partners, they don't know their partner status, or you're in an area or group that has high HIV prevalence, those are all reasons that you can consider someone to be at risk, and you can at least offer them HIV PrEP. So for me, the big one is bacterial STI in the last 6 months. I think there's a lot of people who do get diagnosed with bacterial STI, and we don't necessarily offer them PrEP or link them to places where they could get PrEP. And I think that's kind of a missed opportunity. The other big category of people who we also will talk about later on are people who inject drugs and who share injection equipment. Sharing needles especially is a very, very high risk factor for HIV transmission when it's with someone who has HIV that isn't virally suppressed. And so this is, again, another group that should be offered HIV PrEP. The CDC has a similar guidance. Don't let this chart bamboozle you. But basically, if someone is sexually active, they have an HIV positive partner or multiple partners of unknown status, or they've had a bacterial STI in the past 6 months, then they also should be indicated for PrEP, and it should be offered to them or linked to somewhere where they can get it from. I will add that the CDC also says in their guidelines that anyone who asks for PrEP should be given PrEP. We shouldn't be double guessing why people need it. We should just be offering it to them if they need it and they ask for it and they're indicated. So we don't need to grow up people or give them this 7th degree questioning about why they want it or why they need it. We should offer it to people who ask for it. So we have 3 options here, and I'll talk about each one briefly, and then we'll go into a bit more of the monitoring and prescribing. So the one on the left is Truvada, which is emtricitabine tenofovir disopropyl fumarate. You will also see it referred to as TDF for tenofovir disopropyl fumarate. It's a once daily pill. It's been around the longest and has good data in all categories of people, to be honest with you. Safe in pregnancy, good observational data in pregnancy from sub-Saharan Africa that we know, and it's been used for a long time in pregnancy. In men who have sex with men, it's also available for 2-1-1 dosing, which is a dosing regimen where instead of taking it every day, if people are able to plan for sex, they can take 2 pills 24 hours before sex, and then 1 pill 24 hours later, and then another pill another 24 hours later. And that dosing strategy has been shown to be equal to daily dosing for Truvada in terms of HIV protection. It is not a strategy that's specifically endorsed by the CDC, but they do mention it as something that has good data behind it, and different groups such as the San Francisco AIDS Foundation do endorse that dosing strategy. So it's important to know that that is an option that you may see people using in the community. Side effect, the one that we worry about is renal side effect. So we do monitor creatinine when we start this medicine and periodically as people are on it. The second medicine that we have here in the middle, Descovy, which is M-tricytidine tenofovir alafenamide. You will see it referred to as TAF sometimes for tenofovir alafenamide. That's the newer oral option. It is not approved for 211 dosing. It's a daily pill. It should only be used as a daily pill. It's also only proven in and approved for use in men who have sex with men and transgender women. So this is not, unfortunately, yet an option for cisgender women, but the studies are ongoing. There is not data for this one in pregnancy. And the possible side effect that we worry about is weight gain. So we monitor weight, we monitor lipids as people are taking this medicine. The third option, which you'll see on the right-hand side, is cabotegravir injectable. It's also known as Apretude. This is a great option with good data behind it. You will see it prescribed probably rarely. It's not the easiest thing for some pharmacies to get, and some insurers do require a prior auth. So here in Wisconsin, my impression has been that it's a little bit more difficult to get. Haven't seen it that much. But it's nevertheless, it does have very good data behind it. It's an every 2-month dosing. There's an optional oral lead-in if someone wants to, make sure that they are going to tolerate the medicine well and not have too many side effects. You can have an oral pill leading in for a while. Good data in female patients, but there's not good data in pregnancy yet. And that is a bit of a sticking point. There's ongoing trials. But for some people who don't want to have an oral pill laying around in their house, but still want to protect themselves from HIV, cabotegravir might be a good option. The guidelines kind of allow for some shared decision-making, risk-benefit discussion of how much risk someone might be at if they were to become pregnant, and whether this might be a good option for that person. But it's just worth knowing that there is not good data quite yet. That should be coming out within the next couple of years, we hope. So how about prescribing HIV PrEP? So before prescribing PrEP, the CDC's HIV PrEP guidelines go into this in great detail. They're very detailed, but then they're not too difficult to read through, and you can kind of easily Control F your way through it if you need to look up what test to order when you're prescribing this medicine. The really important one before prescribing any HIV PrEP is an HIV test. We want to make sure that someone doesn't have active HIV infection, because this medicine alone would not constitute a complete treatment regimen for HIV. So we want to make sure that we're catching that if people are starting HIV PrEP. And then also, if someone's kind of cycling on and off it, if someone's using it for a while and then stops and then restarts and stops and then restarts, then we want to be making sure that they are getting HIV tests probably each time they would restart, if that's possible. In the latter scenario that I was just mentioning, if someone's stopping and starting HIV PrEP, the guidelines actually in this last iteration talk about an HIV quant test. So that's looking for actual viral load rather than the antibody test. And the reason is that if someone's starting and stopping HIV, they may take longer to seroconvert. And so we might need to look for evidence of the virus in their bloodstream as opposed to just looking for the antibody. When we're starting, and then again, when we're monitoring people who are on HIV PrEP, the guidelines have us do STI testing And this is STI testing at sites of exposure. So it's places where people have sex. Gonorrhea, chlamydia, and then a serum syphilis test. And we talked about syphilis earlier in this series. In general, I will order this as Q3 standing labs and then monitor. Don't require people to come in every 3 months. That's creating unnecessary barriers for them to continue on the HIV prep. And if you do see them, if things are going well and it seems like all their labs are coming back normal, it's okay also to do follow-ups by telehealth, by a video visit or a phone visit. There's no need to have people come in, every 3 months just to do these labs and bill for a visit if we're not really making any medical decisions. For oral prep, and we'll go into this again in our next slide, but for oral prep, we want to make sure that we're testing hepatitis B. We want to be ruling out an active hepatitis B infection, checking creatinine, like I said, making sure that we're on top of any renal side effect. Hepatitis C, plus minus, I'll get into that, and then lipids, especially for tenofovir alafenamide, which is Descovy. So I know this slide is busy. Again, this is in the CDC guidelines, so don't let it overwhelm you. If you ever need to look it up, you can Google it and it's going to be right there. But if you look on this second column here, when people are starting HIV prep, these are all the labs you want to get. The HIV, the creatinine for renal function, your STI panel, lipids if someone's taking Descovy, and then your hepatitis serology. Hepatitis C is an interesting one. This is actually a recommendation that comes from the Liver Society, and that is they are saying that people who are on men who have sex with men specifically, who are on HIV prep should be tested annually for Hep C. Then once you've started someone on this medicine, oral prep, you are testing every 3 months, syphilis, gonorrhea, chlamydia at sites of exposure. So if that includes throat, if that includes rectum, you want to be making sure that you're getting those swabs as well. At the 6-month mark, if someone has risk factors for kidney problems, then you want to be checking a kidney function test. And then again at 12 months for everyone gets a kidney function test. I know this doesn't have the syphilis, gonorrhea, chlamydia at the 12 months, but in reality, most people would be checking most of these things every 3 months as long as someone is getting the medicines. How about the injectable? The injectable is much easier monitoring. You don't need to monitor for the hepatitis. You don't need to monitor for the kidney function. It's just HIV with the initial visit, and then the next injection is actually at the 1-month visit. So you want to be getting the HIV again at the 1-month visit and then every 2 months thereafter. This does actually make for fairly, I would say, intense startup, because it means that you really need to get the HIV result back before you give them the injection. You can't, unlike with oral prep, have them come in, give them a prescription and get their blood done all at the same time. You need to have them probably get their blood done several days before you plan to do the injection. So it does need several more visits, and it's a bit more intense in that sense. You need to make sure that someone can plan to come in, can get the injection. If you need to do a prior auth, get the prior auth done. The startup can be a little bit more intense for a clinic. But once someone's on it, it's a good option, especially if they have difficulty with pills, if they have difficulty, keeping on track of a pill every day. Or they don't want to have pills laying around in their house. They're worried that someone might find it. This is a good option for them. So those are all reasons that someone might want to have the injectable. Okay. Moving on. So here's a little bit of a quiz. Let's say you see a 32-year-old male in your clinic. They're coming in. They want to be tested for all the STDs. They don't have any signs or symptoms. He uses his penis, bottom, and throat for sex, and he's also interested in starting Truvada for HIV prep. So in this case, what would you test for? I won't, we won't quiz a whole bunch of you with one of those multiple choice tests, but I will just tell you We definitely want to be testing for HIV every time before we're starting HIV prep. Syphilis, absolutely. And then gonorrhea at the sites of exposure. And then because this is a MSM who is starting oral prep, we want to make sure that they're testing for HCV, hepatitis C, and then the hepatitis B serology and the creatinine for renal function. Okay. Let's get into monkeypox. So this was a very big outbreak last year with many cases around the world and across the country. Transmitted through sustained skin-to-skin contact, characterized by these painful skin lesions and scarring. Some people required hospital admission for pain management and symptom management. Treatment with antivirals or with the vaccination if someone had an exposure. And public health mounted a very successful prevention campaign with the Jynneos vaccine. So how is it doing this year? Well, as you can see on the left, that epidemic curve there showed that big spike over the summer last year. And this year we were worried about another spike in cases happening. But really, as you can see in the curve on the right-hand side, the cases were really in the single digits for the United States. And the same is true of Wisconsin, fortunately. Wisconsin really was, spared for the most part, I guess I could say. Didn't get as many cases as some of the surrounding states, fortunately. As we can see here, this map is from the CDC and showed 93 cases. And just a quick reminder about the course of monkeypox, the incubation period, 3 to 17 days. There might be a prodrome that, again, is non-specific. And then people could have a varying course of illness 2 to 4 weeks with these evolving skin lesions that seem to be mostly at sites of exposure, evolving from flat macules to more thickened papules, then some fluid-filled vesicles, pustules, and then scabbing over. The test is with a viral swab of the lesion, and a reminder that this is a reportable condition here in Wisconsin. Here again is the different stages and how long they may last. So as you see, some skin lesions, maybe it's just some redness, then a little red patch, and then thickened papule, fluid-filled vesicle that might then evolve and burst, and then scab over. So here we see some pictures of the different rashes, then non-specific, and it might be reasonable to also test someone for syphilis if you're worried about syphilis, or as Dr. Darby might say, if someone has an ulcer, you might also just want to treat them for syphilis while you're waiting for some confirmation. But by this time, my hope is that most people who might be at risk would already be vaccinated. Here's more pictures here. On the right, you can see some of the worst cases with some of these pustules and vesicles. The vaccination campaign, a very successful campaign, this Jynneos vaccine, 28 days apart, a smallpox vaccine, but it also showed to have protection against monkeypox. For treatment of severe cases, there is an antiviral called tecovirimat, which was shown to have some benefit. Nationally, it's available through a trial, but I believe in Wisconsin, it's available through the Department of Health. And then DHS has a list of places where vaccines are available in local clinics. It's not widely available really anymore as much as it was a year ago, but it should be available if people go hunting for it. Why do we bring this up? Well, we were able to control the epidemic, but it does still seem that there are clusters popping up here and there. Earlier in the summer, there was a cluster in Chicago among mostly vaccinated men who have sex with men. And then just this month, there was a group of new cases in San Diego. So it's worth keeping in the back of your mind that this is an option if you see someone with a possible exposure and some of the characteristic evolving lesions, especially if they haven't been vaccinated. But even if they have, and the other thing I would say is it seems like still a lot of people who should have been vaccinated are not vaccinated. We at UW in our HIV clinic, we are vaccinating as many people as we can. And I continue to be surprised at, the number of people who I would have expected to be vaccinated and are not. So definitely encourage people to seek out vaccination if you think that they might be at risk. All right. Moving on. So let's talk about DoxyPEP, doxycycline post-exposure prophylaxis. So this is coming out of a group of studies. On the left is a study from France published in 2018, and then on the right is a study from the US in San Francisco, which was published just in April of this year. So this is showing that 200 milligrams of doxycycline taken soon after sex among men, homosexual men, and transgender women gives good protection against bacterial STIs, syphilis, gonorrhea, chlamydia. Here we go. So the protection rates were pretty good. They actually showed, between 50 and 80% protection against some of these bacterial STIs. And this was a pretty well-powered study. They showed, as we can see here, of almost 60% improvement between the two groups of their study. The dosing regimen, 200 milligrams oral doxycycline ideally within 24 hours, no later than 72 hours after sex. It's pretty easy to prescribe. Adoption has been fairly rapid. Already several states and local health departments have come out with recommendations and their own guidelines. Here are two handouts that I use when I'm counseling patients about this. On the left, that is a handout from the SF City Clinic. These are both from the SF City Clinic, San Francisco. On the left is a patient guide. They have a similar one in Spanish, which tells you what it is, when you take it, how much you take, and some of the key considerations that we're still thinking about. On the right is a dosing guide, if you will, and the emojis, they're a bit cute, but it's basically explaining to people that if they are having sex regularly over, say, a busy weekend, then it is okay to take no more than 200 milligrams of doxycycline on each day, but then making sure that they also follow that up with the last dose within 72 hours, after their last exposure. There are some open questions with this dosing strategy. Antimicrobial resistance is a concern. It's something that the authors were very thoughtful about when they wrote the study that was just published in April. They did try their best to look at how antimicrobial resistance differed between the different arms, but there definitely are still some questions about this, especially given the fast uptake and how much people are asking for this. Microbiome implications, that's another key question. If someone is taking this frequently, is it going to upset their gut health? And then the last thing is just if and when you talk about this with patients, to make sure that you're saying this is something that's fairly new, we still have questions about this, and use your shared decision-making, explain to them that there could be some benefit, but also some risks of making some microbes resistant and some risks of tummy upset, along with all of the other risks inherent with doxycycline, like photosensitive rash, and pill esophagitis if it gets stuck in someone's esophagus. So I counsel people for those questions. Dr. Dalby, do you have anything you want to add here?
Yeah, I would just say I was initially a little bit skeptical about rolling out DoxyPEP. I mean, gosh, we need something, right, especially to counter rates of syphilis. But I was initially a little bit more skeptical, thinking about what about antimicrobial resistance? What about the microbiome? I feel like we're finally starting to respect that a little bit more. But something that I heard that really reset the way I'm thinking about DoxyPEP is that we are using DoxyPEP in people who are really at high risk for STIs. So it's not the difference of giving somebody antibiotics or no antibiotics. It's the difference of giving people doxycycline in this, you know, intermittent way versus like, you know, doing full treatment doses of, you know, to treat STIs. So that's what I'll add.
Yeah. Thank you. And actually on that topic, the CDC is right now, today's the last day, or tomorrow's the last day, that if you want to submit a comment, the CDC is considering their own draft of guidelines. If you want to, you can go online to the CDC's website or the Federal Register, and you can read the proposed guidelines that they are thinking about adopting. And you can submit a comment, and they particularly welcome comments from healthcare workers, people who work in public health. I will say the Federal Register website is not the most user-friendly. Don't go to it on a iPhone or smartphone. It's definitely something you want a laptop for, because you have to kind of hunt through to find the guidelines. But you can help influence national policy. This is your chance. Tomorrow's the last day. All right, enough of that. How about people with substance use? I wanted to take a moment to think about the co-occurrence of STIs in people who have substance use disorders. So substance uses are an independent risk factor for STIs. Treating one illness without the other, you know, might leave people at some risk of recurrence. I actually came to think about this a little bit in the same way I think about expedited partner therapy. You're kind of leaving a risk factor out there that we could maybe be treating. So I think it's important for us in the STI treatment community, in the public health community, to understand some aspects of addiction medicine. What are some of the important points and new developments in this field, and then really to know what the resources are in your community. If you have someone who has opioid use disorder, if you have someone who has methamphetamine use disorder, how can you treat them, and where could you refer them to in your community? This is a particularly stark example, but chemsex is the use of stimulants like crystal meth or like methadone or GHB to enhance libido during sex, and for people who get hooked into this practice, it can kind of start leading to the entire days lost, where people might be taking crystal meth for several days at a time, spending money, not going to work, and engaging in a lot of very risky behaviors. It's a point of some focus, and there's been some developments in specifically crystal meth treatment in the last couple of years, and so that's what I wanted to bring up here. The Dept 2 trial was published in January 2021. They looked at the use of bupropion at a fairly high dose, 450 milligrams, along with naltrexone, the injectable opioid antagonist, versus placebo. The study design was very, very fun. I won't get into that because I'm sure it's too geeky. But they showed a very high response rate. And the number needed to treat for this trial was 9, which in addiction medicine is pretty good. So as you can see here, on the left and on the right, there's a much higher group of responders among the people who did receive naltrexone and bupropion versus the people who did not. What else do we have for crystal meth? Mirtazapine is another option. Mirtazapine is an antidepressant. It has effects at a number of different types of receptors, but just a 30 milligram daily dose helps with depression, helps with sleep, which is a very difficult thing for people who have crystal meth use disorder. And it helped people abstain from using crystal meth. This, again, is something else that you might see used. This study particularly was in men who have sex with men and transgender women. What has become the gold standard, though, in the last 5 to 7 years is certainly contingency management. So this is where someone might come into clinic, they give a urine sample, the urine sample shows no evidence of any drugs, and then they get a voucher typically, or a prize, like a snack. I was just messaging with one of my former co-residents, and she said that in her clinic, they have people spin a wheel, to get a voucher when they come in for the visit, and then if their urine drug screen is negative, they'll get another spin and potentially another win of another voucher. So it might feel a bit odd to be paying people to not use drugs, but it's been shown to be very, very effective, and it's actually honestly become the gold standard. It can be a bit resource intensive. You do need to have the funds to be able to buy vouchers, and some of the places that have implemented it have done it along with pretty high touch counseling, so needing a social worker for that or needing a counselor for that, but it does have a strong evidence basis. So in places where methamphetamine use is really bad, this is a good option. Opioid use disorder is a really big topic, and it's a bit beyond the scope of this talk, but I will say it's important to be aware of fentanyl contaminants if they are prevalent in your community. If you can take a harm reduction approach with fentanyl test strips, being able to give those to your patients, that can also help reduce their risk of overdose. And then also knowing the treatment, so knowing Suboxone, buprenorphine, and if possible, the longer acting injectable, which is Sublocade. And if you know people who you can refer to who might be able to prescribe that, invaluable, really, really helpful for some of these patients. There's actually strong evidence for Suboxone starts in the emergency department. So emergency department, someone might come in withdrawals, give them some Suboxone, refer them on to someone who can prescribe and take over the prescription on an ongoing basis. There's some very strong evidence for that. Now I'll get into hepatitis C. So we mostly think of hepatitis C as an injection, as a virus that's transmitted with sharing equipment. But it can be transmitted sexually. It's a little bit, honestly, controversial. It's not very efficiently transmitted sexually. The Liver Disease Society would say that it's mostly transmitted sexually among men who have sex with men. So why do we bring this up? Well, we thought that hepatitis C was a disease of baby boomers, and we thought that younger people wouldn't be at risk. Well, it turns out that now younger people are also contracting HCV infections. As you can see on the left, the distribution of age incident for hepatitis C has changed from a bimodal distribution now to kind of more of a unimodal distribution. And on the right, you'll see that, again, we have people of all ages, but especially now more younger people, unfortunately, who are being diagnosed with hepatitis C, including women of childbearing age. As with regard to the geographic distribution, as with many diseases in Wisconsin, the metropolitan areas have the highest numbers. But look at this with hepatitis C, we also see very high per capita rates, even in rural northern Wisconsin and really all over the state. I don't want to spend too much time on hepatitis C, as like I said, it's not the most efficient sexually transmitted disease. But I will say that primary care and public health do have a big role to play in combating the hepatitis C epidemic. It is the most common bloodborne pathogen, and it's something that we really need to help get on top of. It's something that primary care can treat. The access to the medicines has become a lot easier in the last 5 years or so. And on the left, you will see the guidelines that are very easy to read through if you want to become a prescriber who can treat hepatitis C. On the right, if you want to learn more about hepatitis C, there's the online curriculum from the University of Washington, which is very comprehensive. All right, so on to our last topic. So transgender and gender expansive persons. How to think about talking with these people, how to approach STIs in this population. What I want to, so first of all, taking a step back, transgender people whose gender identity is different from the one they were assigned at birth. hopefully, hopefully we all understand that. I want to, highlight that this community does skew very young. Most of them are under 35, and about 1 in 5 are teenagers. So this is a young group of people, and it's a group of people that's growing fairly fast. I look at the Kaiser Family Foundation did a big study last year, which is the one that I use as a reference when talking about this group, because I know when we talk about transgender community, there's a lot of variation. Every transgender person, has their own expression of their gender identity. And so it can feel a bit like it's difficult to talk about the community as a whole. So this is the study that I reference when I like to talk about the community as a whole. Pronoun preferences vary a lot. About half of people in the Kaiser Foundation study use they, them pronouns, and a third were happy with a combination of they, them, or he, she, or he, or they pronouns. And sexual orientation is diverse. Many people will identify as straight who are also transgender, but some might identify as queer or bisexual. This is, for me, one of the big kind of takeaways from the Kaiser Family Foundation study. So this one chart is explaining on the left in the dark blue, among transgender women and men, what are some of the ways in which they express their gender identity. And on the right, they're contrasting that with people who identify as non-binary or gender non-conforming. And I won't go into too much detail on this slide. It's definitely something worth looking up if you want to find out more about the transgender community as a whole and how people express themselves. But what I will say is that it's helpful to know that not all people who identify as trans use hormones. In the Kaiser study, 60% of people who identified as trans use hormones, and of gender non-conforming people, only 17% did. And it's also important to know that a lot of people who identify as transgender do not have surgery, do not seek surgery. In this study, only a third of people who identified as trans had undergone any surgical procedure to affirm their gender. And among gender non-conforming people, that was even less than 10%. So how about people who are on hormones? Well, testosterone for transgender men does cause vaginal atrophy. If someone were to be using testosterone hormone for their gender affirmation and using their vagina for sex, it's quite possible that they might have more abrasions and tearing, and would need to use lubricant, but might increase their vulnerability to contracting an STI during sex. Something that we definitely counsel all transgender men is that unless they have had a hysterectomy, then they can become pregnant. Testosterone will stop periods very effectively, but it doesn't make someone sterile necessarily. It's by and large will, stop ovulation, but we do not guarantee that. And there are some very small number of case studies of people becoming pregnant. So it's important to use contraception. And then the last thing is that if someone has a lot of dysphoria around use of their vagina and they're engaging in anal sex, it's important to make sure that you're screening that area with a rectal swab if they are coming into you for STI screening. How about transgender women? So we have people using spironolactone to block the effect of their testosterone. And then we use estradiol for the cross-sex hormone. The estradiol will have a side effect of fewer erections, can lower libido. There's not the same kind of risk change as with use of testosterone in transgender men. But I will again say that if someone is using their body for sex, when you are screening them for STIs, you need to be checking a rectal swab for gonorrhea, chlamydia. This is a set of questions from the Fenway Guide out of the clinic in Boston to ask people about their sex practices. They adopt language that doesn't assume gender on, you know, the part of the person in front of you or of the person they may be having sex with, personal people they may be having sex with. I won't go through these in a huge amount of detail, but just to know that there are question inventories out there, making sure that we are respectful when we're eliciting a sexual history, and making sure that you're covering everything that we really need to know to get a good comprehensive sexual history, sex partners, protection, STI history, and then risk factors. Anything to add, Dr. Dalby? Nope. Okay. Moving on. STI prevalence among transgender people. Unfortunately, we don't have good data about this. I wish we had better data. But you know, something that we definitely see is that provider and system lack of knowledge and barriers to care does cause people to avoid wanting to go to the doctor. People don't want to go to the doctor if the doctor is going to misgender them, if the doctor is going to make assumptions about the people they're having sex with or how they're having sex. And so unfortunately, we just see a lot of people foregoing care, and that can put them at risk. And really gives the need for us to make sure that we're using gender inclusive language, that we're having, you know, we're giving trauma-informed care. And hopefully if we can do that and be inclusive, then we'll be able to see more uptake of health adoptions, health prevention services by transgender people. And then we might be able to get better data, do more screening. So how to talk to transgender people. Hopefully this is obvious by now, but making sure that we're gender inclusive, that you have kind of an open and respectful way of communicating, trauma informed, and that can mean a lot of things to a lot of people. We throw that term around very loosely, but really kind of not making any assumptions about the person in front of you, what they may have been through in their life. Maybe they come to you with a lot of trauma, a lot of difficulty around talking about their genitals. Maybe they want to use certain words, not want to use other words. Kind of making sure that you ask before you ask, is it okay if we talk about sex now? Is it okay if we talk about different parts of your body? What terminology would you want to use for you know, your private parts? Even something as simple as that, you know, someone may laugh it off, but to other people it may mean a huge amount that you're taking the extra time to make sure that they feel comfortable with you even broaching these subjects. Definitely offering your pronouns, or like I do, if you have a badge that says hello, my pronouns are he him, something like that can go a long way. And eliciting patient pronouns, making sure that you're being respectful and referring to people how they want to be referred to. Specifically for transgender people, the organ inventory can be very helpful to make you sure that you are testing sites of exposure where people are having sex. And if you need to be talking about contraception, talking about the right methods of contraception, there are standardized question sets that you can ask, and where we are practicing, Epic has its own organ inventory that you can kind of click through, which can be very helpful, and then that feeds into what screening people might need. And then lastly, taking comprehensive sexual history, as we mentioned. Like I said, we don't have great data, unfortunately, about STIs among transgender people. This is a slide from the CDC. It doesn't really tell us too much, unfortunately. And if anything, on the left, you can see that most places don't even report gender identity when they're giving their syphilis numbers. This is a very stark and actually very sad slide. So HIV is very prevalent among transgender women, especially 17 to 19-ish% of white transgender women have HIV. Among urban population, that goes up to 4 in 10 among all transgender women and Latinx transgender women. And then among African-American women, the number rises even further up to 6 in 10. So this is a population that, you know, has a need for HIV PrEP. We already went over the vast disparity in access to HIV PrEP. We want to make sure that everyone who needs it can get it. For transgender patients specifically, Truvada is a great option. Like I said, Truvada is proven in almost all categories of humans, and it's safe in pregnancy. The one thing I would add is, like I mentioned, the 2-1-1 dosing. It's only proven in men who have sex with men. So that would not be something that I would necessarily encourage transgender women to have. Descovy, TAF, has not been proven effective for receptive vaginal sex. So I wouldn't propose that for a transgender man who had a vagina. The injectable could be a good option. The WPATH, which is the Transgender Health Professional Society, says to kind of make sure that if you're injecting it, you want to make sure that someone doesn't have filler in the area that you're injecting. But none of these have any interactions with hormones. Screening, again, noting the high risk for HIV among transgender women. You want to be screening based on based on risk factors, and offering HIV PrEP if appropriate. Many transgender women may not be sexually active, and if that's the case, you don't need to offer them HIV PrEP. But just having this awareness about this very high epidemiological risk. And then, of course, transgender women are eligible for DoxyPEP, the doxycycline that we talked about. They were included in the study that was published in April of this year. Making sure that people who are transgender have cancer screenings and other kinds of screening based on anatomy. So, for example, people who have a cervix, transgender men with a cervix under 25 should still have the routine gonorrhea chlamydia screening, as should cisgender women of that age. And then cervical cancer screening, something that might be a little bit more challenging, honestly, with transgender men, but it's something that should be offered regardless. I have some notes now just about some different screening recommendations for transgender people. So like I said, people who are sexually active, and people who have HIV who are sexually active should undergo annual STI screening. People who have had a vaginoplasty, transgender women who have had a vaginoplasty, should undergo screening for STIs, but you do need to be aware of the surgical technique that was used to create the neovagina, as it were, and that it is possible that someone can have pathology inside their neovagina, which would differ depending on how it was created. So, for example, a lot of neovaginas are created with penile eversion technique, and so that means that there is epidermis, skin, inside the neovagina, and that might present with different pathology. You could have, I don't know, dermatitis, psoriasis, things that we wouldn't typically think about as STIs, but that might present. You might have some unusual bleeding, and so keeping a wide differential there. A bit less common is that there can be a surgical technique where people use some colonic diversion for neovagina, and that can present with even different pathology. So people could have even colon polyps or colitis in their neovagina. Metoidoplasty is the gender affirming surgery for transgender men. Sometimes people will have some urethral lengthening if they haven't had the vagina surgically removed. Then being aware that you could have an STI in the vagina. So if you need to test, like we say, test all sites of exposure, you may also need to do a urine test as well as a vaginal swab. And then, of course, transgender men can have pelvic inflammatory disease if they present to you with cervical motion tenderness, lower abdominal pain, some of those things that we think about for pelvic inflammatory disease. Want to keep that high on the differential. Overall, making sure that we're being respectful, inclusive, trauma-informed, using people's preferred pronouns, being aware of the risk of HIV, especially among transgender women, and offering PrEP as indicated. So I think this population is young and growing. There will be more of these people in the next, more transgender people in the next 5 or 10 years. There's a lot of teens who are identifying as transgender, and I think this will be something that we will see more of in the coming few years. So there's some good resources. The treatment guidelines, I'm sure we're all familiar with. The WPATH is the transgender medical professional body. They have their new guidelines, which were just issued last year. Fairly dense. And so if you're looking for something specific, you can use Control F. The UCSF guidelines are a bit better and a bit easier to kind of go through, and they have really clear clinical guidance if you're looking for specific guidance on this topic with regard to transgender care. And that's it. So thank you for your attention. I don't know if we have any questions, Adele.
Yeah, you guys pop into the chat to ask questions if you want. Thank you so much. That was really interesting. If anyone didn't get the event details email, that might have happened if you didn't register online and you registered with me. If you pop your email in the chat, I will make sure I get you a copy of this presentation, because I know there's a lot of good resources in there. I popped a couple things in the chat, but I'm sure I didn't capture everything. If anyone has any questions, feel free to come off mute or pop it in the chat. Oh, okay. So can Doxy be used without PrEP? We have a question.
Can doxycycline be used without HIV PrEP? I would say yes, but that's not the population that it was studied in. So I would say, you know, can you make that prescribe? Can you prescribe it? You can, but it's not the population that it's been proven in. So I'd definitely be a bit cautious about it, and I definitely have a shared decision-making conversation. Dr. Dalby, do you have a?
Yeah, I was just thinking that, you know, the population that needs doxy-PEP is also the population that needs PrEP. But
Yeah.
of course, in our communities, we know that sometimes there can be some barriers to PrEP, whereas doxycycline, just because it's cheap and more readily available, sometimes can be easier to access. So, you know, I do think that doxy-PEP is really an important tool as we are trying to combat some of these rates of syphilis in our community. But, you know, I would, again, the same person who needs doxy-PEP is the same person who needs PrEP.
Yeah.
And so I would really encourage those two together, but again, understanding that sometimes there are barriers to accessing PrEP. You know, doxy-PEP is an additional good step, and you know, maybe something that you start while you're trying to get somebody in for PrEP care. I think that you mentioned this, Dr. Moore, but you know, again, the big thing with doxy-PEP is that it really has not been shown to be effective in cisgender women. So people with vaginas, it has not been shown, doxy-PEP has not been shown to be effective in people with in women, basically. And you know, really it's just for men who have sex with men and transgender women.
Mm-hmm. Yeah.
Not cisgender women.
Unfortunately, yeah. Okay. Thank you, everyone.
Yeah, thank you all
learned
so
something.
much. All right, I will let you go. Y'all will get a follow-up email if you registered. Go ahead and email me if you didn't get something you received, something you expect. I'm going to put my email in the chat. Thank you, doctors. Thanks everyone who attended. I will talk to you soon. I'm going to leave on just a second. Y'all can hop off as you want, just so people can see the chat if they need to. Hey, Dr. Cron.
Hey.
We are all done, but I can send you the recording.
Oh, that would be excellent. I'm so sorry. I was in another meeting that ran significantly over what I expected it to. So I would really appreciate it. Thank you so much.
Yeah, no problem. Have a good rest of your day. I'll
Okay.
make a note to send it to you.
Bye-bye.
Bye. Bye, Jamie. We'll see you soon.